Impression that I am the one who can tell you all about how you should do it. It just possibly it's the correct title that you gave me is how I do it, and this is only one way. So let's be very clear about that. But maybe, unfortunately, this is a video that doesn't work. But I put the slide up anyway. We've tried everything, and we've tried at home, and some computers it works, and others it doesn't. It's the way it is. But this is a little film I wanted to show you of a surgery, thyroid surgery, in 1904 in Paris. And what you see, you are a magician. I'm not saying anything. Just look at the. I don't see suturing. I don't see that. I just see that. It's out. Thank you so much for helping me there with the video. It's just to show you that just a little over 100 years ago, this was a way to do thyroid dissection. It's amazing. It went very fast, but obviously with a lot of bleeding, other problems, etc. And we've evolved to a situation where we have a very controlled situation, good light, a magnification, good assistance, etc., etc. So it's always fascinating to look at this film and see where we came from, and even somehow patients survived this this procedure. So it's very interesting. Talking about difficult thyroid surgery, to me, again, this is a non-evidence-based personal story, is to be divided in three major categories. One is the parathyroids at risk, one is the large goiter, and a little bit about advanced cancer. Starting with the parathyroids at risk, to me, total thyroidectomy, the major and nastiest complication is permanent hypoparathyroidism. Increased risk of such a complication are, and we were talking about this earlier during the case discussion, the prophylactic total thyroidectomy in the very young. And I mean the 938 and 922 mutations in the red proto-oncogene of men patients implores you to do prophylactic surgery before the first year of the newborn. And that obviously, and we've done quite a few because we have a large center, as I told you, a large men population. So we see these patients in families very early. So in these mutations that are very aggressive, generally meant to be associated gene mutations, you have to be very early because they all develop medullary thyroid cancer at a very young age, and you want to be before that. So we do that, but we have a few cases that have required months and months of admittance to the hospital just to control the calcium. So it's a very nasty complication. The other ones obviously are patients who have undergone total thyroidectomy and extensive neck dissection for extended tumor involvement, and even, I told you last year as well, for us, the minimally invasive surgeries for Graves' disease, we're very reluctant to do them, just because technically Graves' disease, in which generally worldwide we're approaching more and more towards a policy of doing a total thyroidectomy. This is the reason why I'm a bit apprehensive of advising that to patients. And obviously redo surgery, which we have to do. So again, not like the film of 1904, but use the enhanced vision, use the loops, use optimal light, or even a headlight if you have one, to be optimally equipped to search for your parathyroids and treat them as gently as you can. About sealing devices, I always use dipolar if I get close to the nerve and the parathyroids, but at least we are very strict. We say within a centimeter. We're a training hospital, so maybe 5 millimeters is fine too, but why not be on the safe side? So if you use it, be at least very aware that not close to parathyroids and not close to the nerve. Use a systematic approach, and if you can, in difficult cases, team up, as I said before. So, if you dissect the parathyroid away, it's like the rose with a long stem, and then the bloom and the blossom of the rose comes out. But the long stem is the problem. And if you remove the wall of the long stem will just break in two. And that's what you want to avoid. So gently pushing the entire stem with the parathyroid to the posterior side. So from anterior to posterior, very gently, will help you. And if you stay on the right, it's difficult to see, but on, let's say, that plane, and just push it gently all the way down, and use your bipolar forceps. That's probably the best way possible to not injure the parathyroid. So it's not mainly the direct injury to the parathyroid that does the trick, but it's the injury to the vasculature, which is tiny. And basically, in most cases, it's the vein that struggles earlier than the artery of the parathyroid does. And what you see then is that the gland becomes cyanotic, and at that stage, I would advise, if you see that, to take it out and autotransplant immediately. The way we do that is basically, I like this slide because it's how to use a knife, and I love using instruments for things that are not meant to be used for, because that's probably the wisest thing to become a creative surgeon. What you do with autotransplantation, you mince the gland in small pieces on a metal or a bowl or a hard surface that you get from the sterile table. Then you create the muscular pocket, whether it's in the forearm or in the sternocleidomastoid, it's up to you. And then first tie the suture. Use a running monofilament suture and tie the first knot. And have the resident or the assistant hold up that suture. Because if you do not do that, and then you take your knife, you scoop up your minced pieces of parathyroid, and because the knife is sharp and because the knife is slippery, you can sort of, as the pizza over there, you can just put it in the little hole and then wipe it off. If your suture is not tight, the whole thing will collapse and all the minced pieces will come out and spill all over your operating field, and that's not what you want. So the holding, having your resident, your assistant, holding that suture tight will allow you to do that maneuver, put the minced particles in, and then you'll have your time to suture, and you can hold your suture yourself. That's the way we do it, and I think I've always been very happy with that. Here I told you already. Here you see I talked last year about the robot-assisted transaxillary thyroid surgery. And the reason why we are very apprehensive to use that on Graves' disease patients is this slide, where you see our operating time and where you see the peaks during the first 100 cases. Now we have 150. But where you see the peaks are the difficult cases, and they were all Graves' disease cases. So we discussed this in our group and said we're not going to go further with Graves' disease for this kind of indications. And of course, there's the matter of fluoro-optics. Things become available if you're in robot situations and you want to visualize a parathyroid. That might help you, but it will not help you really greatly in trying to avoid this kind of vascular complication that I was talking about earlier. Moving over to number 2 is the large goiter. We all know the situation. We are all very serious about, I would guess that you would see slightly more of this kind of goiters than we do, but we also do see them once in a while, and it's always a challenge to operate these patients. Of course, you have to visualize the trachea either by CT scanning and or normal thoracic X-ray. As you can see here, trachea deviation, trachea compression are all very much in focus here. And obviously, as an extension, goiters may be very large, but they can also be very large retrosternally to produce a substernal goiter that requires a somewhat different approach. So the incidence of all thyroidectomies for goiter to approach to gland in part from the surrounding tissues. As I said, be very careful not to injure capsular vessels, and if you do, don't go with energy devices, don't go with trying to use diathermia, just have a large needle monofilament suture like Proline or PDS or whatever, but a large needle and control the bleeding by suturing, not anything else. And then it's very, very tempting to immediately, I always see people do that, immediately try and mobilize that thing out of the substernal plane, but you have to withhold yourself to do that only if you're absolutely certain that you are in the right plane. And it takes generally at least some minutes, if not more time, before you're really in the right plane. It's always taking additional fibrous tissue that you can sort of dissect away from the goiter. You can digitally identify, if possible, but generally it's possible, the neurovascular sheath, which will help you. And you're greatly helped if you can identify the trachea already. And also, as I said before, the gastric tubes or the esophagus. And these will help you to be oriented where you cannot see, because the goiter is right in your face and in front of you, so you cannot do otherwise. If you can, if you're in difficulty, split the isthmus, very important, and you can walk from there downwards. Again, I said before, I'm not against sealing devices. I've put it up 3 times, but I'm not against sealing devices. But my own personal experience is that in these cases, it does not help you the way, it does not help me the way that I use it for these very large goiters. So sometimes I really prefer just the old-fashioned technique with clamps and with suturing or tying. So as I said, as long as you can, move as much fibrous tissue away so that you're truly on the capsula, on the right plane, and then you can attempt to digitally mobilize the gland from caudal all the way up into the operating field. Generally it works. If it doesn't, don't persist, just open the sternum, either partially or totally, depending on the situation. Be aware of the brachiocephalic veins, but then you'll be in an excellent position to put that pressure on. And generally it's disappointing because you've done a huge extra incision, you've done partial sternotomy or whatever, and it's one push on the right point in the goiter, and it will sort of pop out and be in the operating field. And that's the moment that you'll start looking for the recurrent nerve. And in my modest opinion, I think it's rarely necessary to use a limb stimulator because you can relatively easily find it at that point, because the difficulty of the operation is not the involvement of the nerve in 9 out of 10 cases, but even more. Obviously, these are, let's say, open doors with meticulous hemostasis. In these cases, generally, I never use drains. In the very large goiters, I may consider one depending on the situation. And then, of course, you get the whole issue of extubation or not in conjunction with your anesthesiologist, in conjunction with giving steroids as they would like to do. So that is on large goiters. And then a few remarks. We talked about the advanced cancers. I'll show you 2 patients that we have recently had in our practice, who both were 70 plus, both very vital patients. The first one is this gentleman of 74 years, and he was operated elsewhere. And the only thing we knew was that he had a thyroid, or presumably thyroid mass. He was operated on, and they made a biopsy, and it was supposed to be some not very well differentiated tumor, and they tried to get it out, but it didn't work, and they closed up and sent the case to us. So the gentleman recovered, and this was not a small hospital or whatever, but somehow he got a little bit lost along the way. So before he came to us, it was maybe a month or 6 weeks later. And upon transfer, he really, in the outpatient department, he developed a very rapidly, aggressively progressive dyspnea, shortness of breath. It was hoarse, it was everything to get into an emergency situation. So we took him to the OR, and before that we got the x-rays from the other department, at least the radiological description, and we made this CT scan, which was a largely enlarged thyroid mass with I hope you can see, I can't see from here, but you can see thrombus in both internal jugular veins. You can see pathological lymph nodes, and he was coughing blood, and he was in an acute situation. So we took him to the OR, and we managed to biopsy the isthmus. And what we did was we approached the isthmus, and then we were fortunate enough to find a plane between isthmus and trachea, and that's where we did the biopsy. And accordingly, we intubated the guy and had a tracheostomy placed. So that's what we did, and then the pathology came back, and it was a poorly differentiated carcinoma. So there you go, and here, as opposed to what you presented earlier, Shelton, we put this into brought this into the multidisciplinary team, and we opted for a palliative external radiotherapy, considering that with this extension of the disease, we were not able at this point to perform a reasonable resection. It had been tried elsewhere. We were in an acute situation, so we did not go back for attempting to do an R1 resection. We opted for palliative radiotherapy, not 30 times, but I think this patient had 6 times 6 gray, and that was it. And what happened was that he recovered tremendously. So he still has his tracheostomy, but he can swallow not too hard, but decent intake of food. He is relatively comfortable, and his tumor regressed tremendously under this palliative radiotherapy regime. So now we're in a situation where we are discussing: are we going back for surgery? Are we do we plan on doing radioactive iodine after all in the remainder of the thyroid gland? This is the discussion which we're having now. We're tempted to do surgery, but we'll have to await further regression of the tumor. This is one. The second one is a quite similar case. A lady of 72 years old, but the point in this tumor, she also presented with acute airway emergency. So here again, we brought her to the OR. This was the pre-op CT scan. And what you can see in this image here is that the tumor is much higher. It's at the level of the larynx almost. So we were a bit concerned, and the first aspiration diagnostics failed to reveal distinction between squamous cell or a thyroid. It later turned out to be a poorly differentiated thyroid cancer. We made a PET scan with only involvement in the activity in the neck, no further metastases. We had that time. Then we took her to the OR, and her tumor was actually relatively high. So we had all the space in the world to do a formal tracheostomy and secure the airway, and took another big biopsy. And what you can see, what you can see here on the later scan, we defined the diagnosis as a poorly differentiated once more. We gave her a palliative external beam radiation therapy scheme. And one of the things, this is post-therapy, well, one of the things you can really easily see is that there's destruction and ingrowth into the tracheolarynx. So there's no way we're going to do serious surgery here. But she again, this lady recovered well from this whole procedure and has minimal morbidity of the radiation. So the palliative radiotherapy, external beam radiotherapy, in these two cases was very effective. And she has a feeding tube, a percutaneous PEC feeding tube. So, what can I say? Well, Shelto has already alluded to a lot of aspects regarding difficult advanced cancers. Always, airway comes first. That's probably, and as a tertiary referral center, we get a lot of patients in this end stage kind of thing, situation. So there's only one thing to consider, and that's perform a tracheostomy and be able to provide further diagnosis and then put up a palliative or not treatment. You have to have extensive and multidisciplinary pre-op discussion, study your imaging, study whatever you have. Again, be prepared for the worst and discuss that beforehand with patient and family, including a palliative tracheostomy as a worst case scenario, or nothing in the case of the very extreme situations that Shelto was talking about earlier. Whenever you can, perform an ischemectomy, both as biopsy and as access to your trachea. So explore when you're in doubt. I'm not talking about anaplastic now here, but in all these mixed types, resect only when it's realistic, not when there's ingrowth in all the major structures. We are not prepared, except for the internal jugular, not prepared to do any resection of carotid artery, trachea, or larynx. So if you want to do a debulking situation, shave it off there, whereas your muscles may be excised liberally, but not obviously your esophagus. That's often the case that there's encasement of the esophagus as well. As far as the last word on medullary thyroid cancer, particularly also the younger and sporadic cases, these cases we tend to be quite aggressive. Just as we've seen in the case, they are a nightmare because generally after the first lymph node dissection you do, they come back easily, and you can be aggressive at first, and then if you have clear metastases that you can localize and find, not the 5 millimeter we were talking about, but those we tend to be very aggressive until the situation has calmed down. So with that, and a nice wintry or springy kind of typical